Myself, Dr. Krishneshwari. So today we'll go with cardiology session, and what I am going to speak today is from Davidson Practice of Medicine textbook. Okay, so today we will be covering the basic anatomy, physiology, and also investigation, along with some of the what presenting complaints in cardiology. So regarding the cardiology, going to the heart, everybody will be knowing. But for a basic information, I am saying heart is a conical structure that is situated in the middle mediastinum in between the two pleura. And this the job of this heart, the heart works as a pumping unit in the body. So because of the heart, the blood reaches all the part of the body, and also impure blood is carried to the lungs, and pure blood is carried to all the parts of the body. And heart consists of 4 chambers, 2 atria and 2 ventricles. There is right side of the heart and left side of the heart. Right side consists of right atria and right ventricle. Left side consists of left atria and left ventricle. Right side of the heart, it is concerned with the impure blood. That is the blood which is impure. That is, after oxygenation of the cells, the impure blood is carried through major veins, superior vena cava and inferior vena cava to the right atrium. And from the right atrium, it reaches the right ventricle, and it is carried to the lungs. And left side, it is concerned with the pure blood. So pure blood is carried from the lungs to the left atrium, again to the left ventricle, and from the left ventricle arises the aorta, which pumps the blood to all the parts of the body. So this is regarding the coronary circulation. It is very, very important. So heart supplies blood to all the parts of the body. But heart is a muscular structure. It is made up of modified cardiac muscles, which also needs blood for its activity. So the heart receives blood through the coronary circulation or the coronary artery. And the coronary artery, there are 2 coronary arteries, right coronary artery and the left coronary artery, which arises from the root of the aorta. So as the previous slide suggests, aorta arises from the left ventricle, and this aorta supplies pure blood to all the parts of the body, that is systemic circulation. So this coronary artery, it arises from the root of the aorta. There are two coronary arteries, right coronary artery which supplies the right side of the heart, and left coronary artery which supplies the left side of the heart. So regarding the coronary artery, this right coronary artery, it comes downwards and it gives rise to marginal branch, and also posterior interventricular branch. Be very careful. This is very, very important. Right coronary artery, it gives rise to marginal branch and also posterior interventricular branch. It is also known as posterior descending branch. Posterior interventricular branch, it is also known as posterior descending branch. And left coronary artery, it gives rise to circumflex coronary artery, left circumflex coronary artery, and also anterior interventricular branch. It is also known as left anterior descending branch. Posterior interventricular branch or posterior descending branch, it arises from the right coronary artery, and the circumflex coronary artery and the left anterior interventricular branch or anterior descending artery arises from the left coronary artery. So the thing which I want to say is, there is right coronary artery and there is left coronary artery, and it arises from the root of the aorta. Right coronary artery, it is concerned with the marginal artery and also posterior descending artery. Left coronary artery, it is concerned with the circumflex artery and the left anterior descending artery. Hope you understood. So regarding the branches of coronary artery which supplies to different parts of the heart, it is very, very important. So this right coronary artery, it supplies the right atrium. So in this figure, this is right coronary artery, this is right atrium, this is right ventricle, and this is left ventricle. So this right coronary artery, it travels in between the right atrium and right ventricle, is it not? So this right coronary artery, it supplies the right atrium, right ventricle, and postero-inferior part of left ventricle. Postero-inferior part of postero-inferior part of left ventricle. Left ventricle is like this, postero-inferior part, and it supplies the postero-inferior part of left ventricle also. Postero-inferior part of left ventricle. And also very important, please listen, posterior descending artery in 90% of right dominant people, it supplies the inferior part of interventricular septum. So right coronary artery in 90% of right dominant people, it supplies the inferior part of the interventricular septum. Hope you understand. Then very important thing, this right coronary artery, it supplies the SA node in 60% of people and AV node in 90% of people. So this SA node and AV node is very important. These are frequently asked question. SA node in 60% and AV node in 90%. It is supplied by the right coronary artery. And for your information, this SA node and this AV node, it is situated in the right atrium. Okay, SA node and AV node, it is situated in the right atrium, and right coronary artery supplies the right atrium, by which it supplies 60% of the SA node and 90% of the AV node. Okay, next, regarding the left coronary artery. Left coronary artery, it is divided into two main branches. One is anterior descending artery and the circumflex artery. So this anterior descending artery, it supplies the septum, anterior, lateral and apical part of left ventricle. So this is the anterior descending branch. This is the anterior descending branch. It supplies, so see, it supplies the septum, it supplies the left ventricle also. And circumflex artery, it supplies the posterior, inferior and lateral aspect of left ventricle. So this is circumflex artery, it supplies the posterior, inferior and lateral aspect of left ventricle. You understand? So circumflex artery, left anterior descending artery. Circumflex artery is very important because this circumflex artery, it supplies the left ventricle, most part of the left ventricle, and the most important artery to be affected in coronary, in heart attack or myocardial infarction is left coronary artery, mostly circumflex coronary artery. Okay, it is known as widow's artery, circumflex coronary artery. So we will come into it later. And already we have told that in right dominant people, 90% right coronary artery supplies, and in the left dominant people, circumflex coronary artery supplies the inferior part of interventricular septum. Hope you understand. The important things you should remember in this slide is regarding the SA node and AV node. RCA, right coronary artery supplies, and also circumflex coronary artery, it mostly supplies the left ventricle. So regarding the direction of blood flow through the heart. So whatever I am saying here is from the Davidson. Please have a look into it, and I have prepared only the important things from that. Okay. So direction of blood flow through the heart. So in the first slide, we have discussed that there is a right part of the heart and left part of the heart. Is it not? So the right side, it is concerned with the impure blood. So in this figure, which is given in blue color, is the right side, which is concerned with the right side, and which is given in red color is concerned with the left side of the heart. Always remember, right side is impure and pure, and left side is pure. So what happens is, in the right side, superior vena cava and inferior vena cava. Superior vena cava carries impure blood from the upper part of the body, and inferior vena cava, it carries blood from the lower part of the body, impure blood, and it drains into the right atrium. You can see right atrium here. So from the superior vena cava and the inferior vena cava, impure blood from all the part of the body is drained into the right atrium. Understood? From the right atrium, it goes to the right ventricle. So this right atrium and right ventricle is separated by means of a valve known as tricuspid valve, because this valve consists of three cusps. So it is known as tricuspid valve. You understand? So what is the function of the valve? Valve allows the flow of blood only in one direction. It will not allow the back flow of blood. So if it allows the backflow, then there is a problem with the valve, which we will be discussing later. So here what happens is, tricuspid valve opens and the blood is carried to the right ventricle. You understand? From the right ventricle, there arises a thing or a artery known as pulmonary artery. So you remember, artery always carries pure blood in our body, except pulmonary artery and umbilical artery. Okay, this is very, very important question. All artery carries pure blood in our body except pulmonary artery, which carries impure blood from the right ventricle to the lungs. Okay, so now the blood from the right ventricle is taken to the lung through pulmonary artery. And this ventricle and pulmonary artery is supplied or is separated by means of a valve known as pulmonary valve, which is a tricuspid valve. Understand? So it is by means of this tricuspid valve, this valve opens and the blood from the right ventricle is carried to the pulmonary artery to the lung. You understood? So this is regarding the direction of blood in the blood flow in the right side of the heart. Then coming to the left side. This pulmonary veins carry pure blood from the lungs. That is, this pulmonary artery carries impure blood from the right ventricle and it is carried to the lungs. And in the lungs, after oxygenation of the blood, pulmonary vein carries the pure blood. So again, important point, every vein in our body carries impure blood except pulmonary vein. So every artery in our body carries pure blood except pulmonary artery, and every vein in our body carries impure blood except pulmonary vein. Okay, so the pure blood from the pulmonary vein is the pure blood from the lung is carried by the pulmonary vein and it is taken to the left atrium. Okay, left atrium, and from the left atrium there is a valve known as mitral valve. And the important thing here is mitral valve is the only bicuspid valve which is present in the heart. Okay, mitral valve is the only bicuspid valve which is present in the heart, and through the mitral valve, this blood from the left atrium reaches the left ventricle, and from the left ventricle arises aorta, which is the largest artery, and the aorta gives so many branches, it supplies the whole part of the body. Okay, so aorta, the blood from the left ventricle reaches the aorta again by an aortic valve, which is also a tricuspid valve, and through the aorta, the blood reaches all the part of the body. So the important thing to remember is right atrium and right ventricle is separated by means of tricuspid valve. Right ventricle and pulmonary artery is separated by means of pulmonary valve. Left atrium and left ventricle, it is separated by means of mitral valve. Left ventricle and aorta is separated by means of aortic valve. Except mitral valve, all the other three valves in heart is tricuspid valve and mitral valve is bicuspid valve. Okay. Then next, very important thing regarding the cardiology, which so many questions are asked, is regarding the jugular venous pulse. Jugular venous pulse, it is the pulse which is not palpable, which is only visible. Usually the pulse are palpable, is it not? We used to feel the pulse, but in case of jugular venous pulse, this is a venous pulse, it is not an arterial pulse. We used to feel the arterial pulse, but jugular venous pulse, it is not palpable, it is only visible pulse. Okay, so this jugular venous pulse, importance is that we will go and we will say, so see, this is the important points regarding the jugular venous pulse. It is non-palpable, so we cannot palpate jugular venous pulse, and it is readily occludable. Occlusion, we can occlude the jugular. We cannot palpate, but we can occlude the jugular venous pulse. And the location of the jugular venous pulse, it is between the heads of the sternocleidomastoid muscle, lateral to the carotid. You understand? So medial side is carotid artery and lateral side is jugular vein. Then inspiration, it drops with inspiration. That is the height of the jugular venous pulse reduces with inspiration. And contour is biphasic waveform. So when we draw this jugular venous pulse in the form of a wave, it is biphasic and drops when sitting erect. So inspiration and also sitting erect will reduce the height of the jugular venous pulse. Hope you understand. The important thing is jugular venous pulse reduces with inspiration and the height reduces with sitting position, erect position. You understand? And the location, it is between the heads of the sternocleidomastoid and it is lateral to carotid and it is non-palpable. Very, very important. It is non-palpable. See. So what is the normal range of jugular venous pulse? So when the person is in reclined at 45 degree, when a person is reclined at 45 degree, from the mid right atrium up to the sternal angle. You all know about the sternal angle. Sternal angle is the place where the manubrium sternum and the body of the sternum meet together. So in the mid right atrium to the sternal angle, the height of the jugular venous pulse is 5 centimeter. Okay, is 5 centimeter. And from the sternal angle at the top level of the venous pulsation, that is in a normal person, when we measure jugular venous pulse from the sternal angle to the height where we are seeing this jugular venous pulse, it is 3 centimeter. Be very careful. From the sternal angle to the height of the maximum height of the jugular venous pulse in a normal person, when the person is in reclined position at 45 degree, the height is 3 centimeter. Okay, 3 centimeter. So total the normal is 8 centimeter. You understand? So we cannot see the 8 centimeter. We can see only the 3 centimeter from the sternal angle till the top level of the venous pulsation. It is 3 centimeter. So normal, if the question is asked this, the height of the venous pulse, the height of the jugular venous pulse from the sternal angle to the top level, it is 3 to 4 centimeter. Okay, 3 to 4 centimeter. And if the question is asked when the height of the jugular venous pulse, the pressure of the jugular venous pulse from the mid right atrium to the top level of venous pulsation is 8 to 9 centimeter. I think you got the point. So from the sternal angle to the height, it is 3 to 4 centimeter. From the mid right atrium to the top level of venous pulsation, it is 8 to 9 centimeter of water. It is water. Okay, 8 to 9 centimeter of water. And if it is more than 9 centimeter, then there is some problem within the right atrium. There is some increased pressure, or there is some right atrial, there is some right-sided heart failure. Okay, so if there is increase in jugular venous pulse, there is some problem with the right side of the heart. And normal, you should be very careful. Normal is from the sternal angle to the top level of the venous pulsation, it is 3 to 4 centimeter. From the mid right atrium to the top level of the venous pulsation, it is 8 to 9 centimeter of water. Okay. So regarding the normality of the JVP, normality of jugular venous pulse, there are so many waves. Okay. There are 3 positive waves, A, C, and B. So 3 positive waves, A, C, and B, and 2 negative waves, X and Y. Okay, ascend and descend. Ascend means it is upward. A, C, V are ascending waves. It is upwards. And X and Y are descending waves. That is, it is looking downwards. So when we draw a baseline, ACV will be upwards and X and Y will be downwards. So wave A, it is related with atrial contraction. Okay, atrial contraction. C. Wave C is bulging of closed tricuspid valve into the right atrium during isometric systole. That is, when there is atrial contraction, what happens? The blood from the atrium flows towards the ventricle. We know that. In the previous slide, we have seen that. So when there is atrial contraction, the blood from the atrium flows towards the ventricle. Is it not? So ventricle will be in diastolic phase. Ventricle will be in relaxed phase. So what happens? Once the atria contracts completely, the blood from the atria flows towards the ventricle, and suddenly what happens? The tricuspid valve shuts. Tricuspid valve closes. So when the tricuspid valve, so when there is increased pressure, A wave is produced, and when there is decreased pressure due to the sudden closure of the tricuspid valve, what happens? There will be a negative wave X. You understand? Negative wave X. So what happens is C wave. C wave, what happens is when the tricuspid valve closes, and this ventricle will be in isometric systolic phase. So what happens is suddenly there will be a small bulge of the leaflet of the tricuspid valve towards the right atrium, which produces a C wave. You understand? You understood. A is atrial contraction or atrial systole, and C is due to, and X is due to the downward movement of the tricuspid valve. That is closure of the tricuspid valve, and this C wave is produced by a small pressure which happens due to the movement of the closed tricuspid valve towards the upward movement of the closed tricuspid valve towards the right atrium. So you are clear, I think. A, C, and X. Then V. V is produced by venous filling. That is from the right ventricle, blood is to the vein. That is pulmonary artery. It supply. That is venous filling. That is systemic. Our SVC and IVC, superior vena cava and inferior vena cava, and Y is due to atrial empty. Y is due to atrial empty. So this is ACV, X and Y. So you can remember this by this thing. Wave A, it relates to atrial contraction. C, so bulging of the tricuspid valve. X, the tricuspid valve moves downwards. V, venous filling, and Y is atrial empty. I hope you understand. So this is very, very important regarding our MCQ is concerned. So hemodynamic effects of respiration. So what happens in a normal person when he respires in case of this hemodynamic effects? So jugular venous pressure falls during inspiration. What happens during inspiration? You just imagine. So we are going to inspire, is it not? So what happens in inspiration? The diaphragm. So thorax will be giving maximum place for the maximum air to enter from the surrounding to the lungs, is it not? So what happens? Diaphragm moves downwards and the ribs will be expanding. So there will be what? There will be more space inside the thorax, that is lungs, inside the thorax. So this pressure in the thorax is less than that of the what? Surrounding. Okay, so inspiration, jugular venous pulse falls. Jugular venous pulse falls because the what? There is the pressure is less, and also there is increased right atrial filling, increased venous return. Venous return will be more at the time of inspiration. So what happens? Jugular venous pressure falls, and during expiration it rises. This is normal thing what we are saying. Jugular venous pulse falls during inspiration and rises during expiration. These are frequently asked questions. That's why I kept this. And blood pressure, inspiration, it falls up to 10 millimeter of mercury. Falls up to 10 millimeter. Very, 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 very important. Blood pressure falls up to 10 millimeter of mercury during inspiration, and it rises with expiration. Okay. Then regarding the heart rate, there is acceleration in inspiration, but in expiration, heart rate slows down. And regarding the second heart sound, so what is first heart sound? First heart sound, it is due to the closure of what? Mitral and tricuspid valve. Second heart sound, atrial and aortic and pulmonary valve. Aortic and pulmonary valve. So there are two components of second heart sound, that is A2 and P2. A2 represents aortic valve closure and P2 represents pulmonary valve closure. So what happens during inspiration, as we have told earlier, what happens? The intrathoracic pressure is less, is it not? And also there is increased venous return. Venous return is more in the right side of the heart. And the right ventricle, when compared to the left ventricle, the thickness of the right ventricle is lesser. The thickness of the right ventricle is about 3 to 4 millimeter, and the thickness of the left ventricle is 10 millimeter. So 3 times more than that of the right ventricle. So what happens? Venous return is more during inspiration. Already the right ventricle is what? Less, the strength is less when compared to the left ventricle. And also there is increased venous return. You understand? You got the point, I think. Increased venous return. So again, the activity of the right ventricle will be slowed down. Okay. But the left ventricle, it is very strong when compared to the right ventricle. It is 10 millimeter. Thickness is 10 millimeter. So what happens? Once the blood reaches the ventricle, left ventricle suddenly pushes the blood towards the aorta. You understand? But what happens to right ventricle? It is weak already and there is increased venous return during inspiration. So what happens? This right ventricle slowly pushes the blood to the pulmonary artery. Understand? You got the point. So what happens? This right ventricle, the stronger left ventricle pushes the blood to the aorta as soon as the blood reaches the left ventricle. You understand? So what happens? Suddenly the aortic valve closes during inspiration. So the first sound which we heard during inspiration is aortic, A2, and the second heart sound is P2. The slower, the less, and the weaker right ventricle will push the blood slowly to the pulmonary artery and it is closed slowly. You understand? So during inspiration, there will be splitting of the second heart sound, and the first sound which we heard is due to the closure of aortic valve, which is represented as A2, and the second heart sound is due to the closure of pulmonary valve, which is represented as P2. So there will be splitting of the second heart sound during inspiration, and in expiration it fuses. I hope you understand. So the thing you should remember here is jugular venous pressure falls during inspiration. Blood pressure falls up to 10 millimeter of mercury. You remember this thing, it falls up to 10 millimeter of mercury during inspiration. Heart rate, it accelerates during inspiration, slows during expiration. And second heart sound, it splits during inspiration and fuses during expiration. So you understood the physiology behind that. And the thing I told, blood pressure reduces up to 10 millimeter of mercury during inspiration. Is it not? Here, there is something known as pulsus paradoxus. Very, very important question. Pulsus paradoxus. There is exaggerated fall in BP during inspiration. Normally, as we discussed earlier, BP reduces up to 10 millimeter of mercury during inspiration. But when there is exaggerated fall in BP, that is when there is increased, when there is fall of BP greater than 10 millimeter of mercury, it is known as pulsus paradoxus. Pulsus paradoxus. I repeat, pulsus paradoxus, exaggerated fall in BP greater than 10 millimeter of mercury during inspiration. And the condition where pulsus paradoxus is present is severe airway obstruction after bronchial asthma or COPD, and also cardiac tamponade. So we will be discussing cardiac tamponade and all. This pulsus paradoxus, you keep in mind, which is very, very important. It is seen in severe airway obstruction, that is like bronchial asthma and COPD, and also in cardiac tamponade. Okay. Okay. And we will go to the next slide. Next, we are going to the investigation. What we have discussed till now is regarding the normal anatomy, physiology, and when there is some change in the anatomy and physiology. So JVP, we were discussing when there is right heart failure or something in relation to right heart, there will be increased JVP. So we will be discussing in classes, in coming classes where JVP increases and all. And also you remember pulsus paradoxus and also splitting of the second heart sound during inspiration. Then we are moving to the investigation of the cardiology. So ECG, we are not discussing too much and all. ECG, you remember there are chest leads and limb leads in ECG. There are two types of limb leads, that is augmented limb leads and also bipolar limb leads. Unipolar are augmented and bipolar limb leads, and also chest leads. There are 6 chest leads. So AVR. So regarding the unipolar limb leads, AVR, AVL, and AVF. It is also known as augmented limb lead. AVR, AVL, and AVF. AVR, it is present in the right arm. It is not present. We are placing this in the right arm. AVL, it is placing in the left arm, and AVF we are placing it in the left foot. So you just take a note of this. There are two types of leads, limb leads and chest leads. Regarding the limb leads, there are two types of limb leads. One is augmented limb leads, and next is the bipolar limb leads. Augmented limb lead, it is also known as unipolar limb leads. AVR, it is placed in the right arm. AVL, it is placed in the left arm. And AVF, it is placed in the left leg. Okay, this is regarding the unipolar or augmented limb leads. And regarding the bipolar limb leads, lead 1, lead 2, and lead 3. Lead 1, lead 2, and lead 3. Lead 1, it connects right arm with the left arm, with negative in the right arm and positive in the left arm. Lead 1, it connects right arm with the left arm, negative in the right arm and positive in the left arm. Lead 2, it connects right arm with the left leg, right arm with the left leg, with negative in right arm and positive in the left leg. Lead 3, it connects left arm with the left leg, with what? Negative in the left arm and positive in the left leg. You understood, I think. So we are not going to the details of the ECG and all, just points what we need. And there are 6 chest leads, numbered from V1 to V6. V1, it is placed in the 4th intercostal space, left side, right side, 4th intercostal space, right side. V2, it is placed in the 4th intercostal space, left side. V4, it is placed in the 5th intercostal space in the mid-clavicular line. So V1, V2, V4. And V3, it is placed in between V2 and V4. So V4, mid-clavicular line, left 5th intercostal space. V5, anterior axillary line, left 5th intercostal space. V6, mid-axillary line, left 5th intercostal space. Hope you understand. V1, only chest lead which is present in the right side is what? V1. All the other leads in the left side. V2, left side, 4th intercostal space. V4, mid-clavicular. V5, anterior axillary. V6, mid-axillary. And V3, between V2 and V4. Okay, we are not going to the details and all. See where the lead cease. We are going to discuss. Okay, so lead 1 and AVL. You see here, you listen here, lead 1 and AVL. It sees the what? Left ventricle, lateral aspect of the left ventricle. So this is the left side of the heart. So lead 1 and AVL sees the lateral side of the left ventricle. Okay. Okay. Then lead 2, lead 3 and AVF. Lead 2, lead 3, AVF. It sees the inferior surface of the heart. Inferior surface of the heart. So no problem. You just listen. Very, very easy. But it is a frequently asked question. Lead 1 and AVL. It sees the lateral surface of the left ventricle. Along left lateral surface of the heart. Lead 2, lead 3 and AVF. It sees the inferior surface of the heart. AVR. It sees the left atrium. AVR. It sees the left atrium. Okay. AVR sees the left atrium. Left atrium forms the base of the heart, and the left ventricle forms the apex of the heart. So AVR, it is in the right side and directly it sees the left atrium, which is the base of the heart. And V1 and V2. Okay, V1 and V2, it sees the right atrium. V3 and V4, it sees the interventricular septum. V5 and V6, it sees the lateral and inferior aspect of the left ventricle. Okay, from the figure itself, you can see, and for better understanding, I have put this slide. Lead 1 and AVL, it sees the left lateral surface. Lead 2, 3 and AVF, it sees the inferior surface of the heart. AVR, it sees the cavity of the left atrium. V1 and V2, it sees the right ventricle. V3 and V4 in the ventricular septum. V5 and V6, anterior and lateral wall of the left ventricle. Okay. So regarding the ECG waves, P wave. So this will be asked frequently. Which waves represents atrium? Which waves represents ventricle? Like that. So the important point which you have to remember here is P wave. The only wave which represents atrium in ECG is P wave. P wave. Very, 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 very important. The only way which represents atrium in ECG is P wave. And P wave, it represents atrial depolarization. P wave represents atrial depolarization. Next, QRS. It is a complex because there are three waves, Q, R, and S. So this QRS, it represents the ventricular depolarization. Ventricular depolarization. T wave, it represents the ventricular repolarization. Hope you understand. P wave is the only way which represents the atria of the heart in the ECG, and it represents atrial depolarization. QRS complex, it represents the ventricular depolarization, and T wave, it represents the ventricular repolarization. So what about atrial repolarization? So there is no wave in ECG which represents the atrial repolarization, atrial repolarization, because once the atrium starts repolarizing, atrium is very small when compared to the ventricle. So ventricular starts depolarization immediately, and this atrial repolarization, it is not signified in ECG wave. Okay. So the P wave, the length of the P wave is 0.12 second. QRS complex is 0.10 second. PR interval is 0.20 second, and QT interval is 0.42 second. Okay, so this is about the normal ECG. Now, how to read a 12-lead electrogram? It is electrocardiogram. It is from the Davidson. So rhythm strip. What is known as rhythm strip? The lead which is known as rhythm strip is dash. Like that, the question will be asked, and it is lead 2. Because lead 2, if we are taking lead 2 for a longer time, we can read the rhythm of the heart. Heart rate and rhythm can be identified easily from lead 2. And so, if it is taken for a long time, in order to identify the heart rate and rhythm, it is known as rhythm strip. Most important, rhythm strip is lead 2. If you hear rhythm strip somewhere, you just tick as lead 2. Okay. Next is cardiac axis. Cardiac axis is normal if QRS complexes are positive in leads 1 and 2. Lead 1, 2, and AVF is also very important. Normal cardiac axis if QRS complex are positive in lead 1, 2, and also AVF. Then P wave shape. So as already we discussed, P wave is the only wave in ECG which represents the atrium. And tall P waves. If the P wave is very tall than usual, then it is known as P pulmonale. There is right atrial enlargement. So when there is some problem with the right atrium, what happens is this P wave will be unusually tall than the normal, and it is known as P pulmonale. And if there is some problem with the left atrium, what happens is there will be notching of the P wave. P wave will be double P wave will be there. Okay, double P wave, and it is known as P mitrale. P mitrale. So P mitrale. So this P pulmonale, which is in connection with the, see, you understand like this, pulmonary artery or pulmonary valve. It is pulmonary artery arises from the right atrial, right ventricle, right ventricle, and pulmonary valve is present in the right side. Okay, so P pulmonale, there will be increased height of the P valve, and it is in concern with the right side. And what about mitral valve? Mitral valve, it is present in between the left atrium and left ventricle. So it is considered the left side. So there is some problem with the left side of the heart, M-shaped mitrale M, and also P wave is M-shaped, and it is known as P mitrale over. Okay. Then PR interval. PR interval normally 0.12 to 0.20 seconds. When there is prolongation of the PR interval, there is atrioventricular nodal conduction defect. That is, this is PR interval. Okay. Yes. So this is PR interval. So from the SA node, it is reaching towards the ventricle. Okay, from the SA node, it is towards the ventricle. So when the PR interval is prolonged, what happened? PR interval is this one, from here to up to Q. So when it is prolonged, what happens? There is conduction, nodal conduction delay. You understand? Nodal conduction delay. See, ECG, you just see the waves and you just study. Otherwise, it will be difficult for you to memorize. regarding the P wave, it is concerned with the atria. If there is increased height, P pulmonary. If it is M shaped, it is P mitral. And mitral means it is in the left side. Okay. PR interval, if it is prolonged, what happens? There is AV nodal conduction delay. You understood? Next. And also, if the PR wave is very short, if the PR interval is short, if it is long, there is AV nodal delay. And if it is short, what happens? There is seen in Wolff-Parkinson-White syndrome, WPW syndrome, Wolff-Parkinson-White syndrome. It is what happens is there will be additional band of conductive tissue. So what happens suddenly, rather than normal, it will be conducting very quickly. This AV nodal delay will, conduction will be less. Wolff-Parkinson-White syndrome, PR interval is reduced. It is increased in AV nodal delay. Then QRS. We all know that QRS, it is concerned with ventricular depolarization. So this QRS duration is, if it is what greater than 0.12 second, there is ventricular conduction. That is bundle branch block. We all know that there is a bundle branch, Purkinje fibers, bundle branch, SA node, AV node, bundle branch, Purkinje fibers, bundle of his bundle branch, Purkinje fibers. So regarding the ventricles, this bundle branch and the Purkinje fibers is supplying the impulse. So what happens when the QRS amplitude is more, QRS duration is more, there is some block. There is some block in this bundle branch. That's why it takes time for conduction. So QRS duration is more, there is bundle branch block. Okay. Then QRS amplitude, if there is increased or less. So when there is, it is slim. When the QRS is small, large QRS complexes, it is seen in slim young patients and in patients with left ventricular hypertrophy. So left ventricular hypertrophy, what happens? There should be more conduction towards the left ventricle. So what happens? The muscle mass is more, and there should be the conduction should be also more in order to conduct all this, in order to excite all these muscles. So the QRS amplitude, the width of the QRS is more. Okay. Then Q waves. Very, very important. If there is prominent Q waves, it is previous MI. Q wave represents previous myocardial infarction. Very, very important. If there is presence of Q wave, it represents dash, acute MI, chronic MI, or previous MI. The answer is previous MI. Okay, Q waves, previous MI. Then ST segment, important. ST segment elevation. When there is elevation of the ST segment, it represents myocardial infarction. The first and foremost thing you should rule out when there is ST elevation is myocardial infarction, MI, and also pericarditis or left ventricular aneurysm. Pericarditis or left ventricular aneurysm. Pericarditis or left ventricular aneurysm. And when there is ST depression, it is ischemia or infarction. So when there is ST elevation means myocardial infarction, most important. Second is pericarditis or left ventricular aneurysm. But ST depression, it may be ischemia or infarction. Understand? ST segment elevation is myocardial infarction. ST segment depression is ischemia or infarction. Next is T wave. T wave inversion. T wave inversion means may be seen in myocardial ischemia or infarction and also electrolyte disturbance. T wave, it is inverted in myocardial ischemia or infarction and electrolyte disturbance. Then QT interval. QT, which is QT? Yes, Q. From the start of Q to the end of T. QT interval. QT interval. So when there is any change in the QT interval, normally 0.42 second QT. If it is prolonged, it is occurs in congenital long QT syndrome or very important hypokalemia, hypomagnesemia, and hypocalcemia. Hypocalcemia, hypokalemia, hypomagnesemia. QT interval is prolonged. QT interval is prolonged. Okay. So the important thing which you should carry in your mind from this table is cardiac axis. It is normal when 1, 2, and AVF. 1, 2, and AVF is positive. Rhythm strip is lead 2. PR interval, it is prolonged when there is AV nodal delay. and it is less when there is Wolff-Parkinson-White syndrome. QRS duration, it is increased when there is bundle branch block. QRS amplitude, QRS amplitude is more when there is left ventricular hypertrophy. Q wave, Q wave. What is Q wave? It represents previous myocardial infarction. ST segment elevation, the most important thing is myocardial infarction, and the other thing is pericarditis and left ventricular aneurysm. And ST depression, it may be infarction or ischemia or infarction. T waves, T inversion, it may be infarction or ischemia and also electrolyte disturbance. But prolonged QT interval, hypomagnesemia, hypocalcemia, and also hypokalemia. Then, regarding the ECG convention, when the depolarization is towards the electrode, there will be positive deflection. When it is away from the electrode, there is negative deflection. 10 millimeter in ECG paper is equal to 1 millivolt. Paper speed 25 millimeter. So this paper travels 25 millimeter in 1 second. Each large square is 0.2 second. Each small square is 0.04 second. Heart rate is 1,500 divided by number of small squares between the RR interval, or 300 divided by number of large squares between the RR interval. So heart rate 1,500 divided by number of small squares between the RR interval, or 300 divided by number of large squares between the RR interval. So hope you understand ECG. These are the important points. Just I am saying, okay, for a refreshment. This is a refreshment course, is it not? So we should refresh everything. We should not miss any point. Okay. So this is a very important section as far as cardiologic, short note, cardiologic MCQ is concerned. This is regarding the biomarker, cardiac biomarkers. The most important thing is CKMB, creatinine kinase, okay, MB. So the time of, so this cardiac biomarkers increases when there is myocardial infarction, that is when there is injury to the cardiac muscle. What happens? This cardiac biomarker increases. So this CKMP at the time of release after MI is 3 to 12 hours after MI. Mean peak time is 18 to 24 hours, and time of return to normal is 48 to 72 hours. First, you remember CKMP, cardiac troponin I, cardiac troponin T. Okay, these are the three important things which you should remember. Mostly this question will be revolving around this. Okay, CKMB, cardiac troponin I, cardiac troponin T. All the others are important that we will discuss. CKMB 3 to 12 hours, time of release, both the cardiac troponins are also 3 to 12 hours. And peak time. Peak time is CKMB 18 to 24 hours, cardiac troponin I is 24 hours, cardiac troponin T is 12 to 48 hours, and time of return to normal. See, this CKMB, it will return suddenly 72 hours. Okay, 72 hours, that is within 3 days. But cardiac troponin I, it is 5 to 10 days, and cardiac troponin T 5 to 40 days. And the most important biomarker which we use to see when we see some change in ECG. Change in the myocardial infarction, change in ECG is ST segment elevation, T wave depression. So the most important cardiac biomarker which we use to see is cardiac troponin I. Cardiac troponin I is sensitive. Cardiac troponin I. So CKMP, cardiac troponin I, cardiac troponin T. These are the other things, but we should remember these three things are very, very important. Usually the questions will be with this CKMB, cardiac troponin I, and cardiac troponin T. Regarding the X-ray features in cardiology, I'm not talking about the lungs, I'm talking about only the cardiac shadow. Okay. So what we will be observing, this is a chest X-ray PA view, chest X-ray, normal chest X-ray. The view is PA view, that is posterior view. What we observe in cardiac shadow is, what this represents is the aortic arch. Next is pulmonary artery, that is left pulmonary artery, left atrial appendage, left ventricular apex. So these are the things which we observe in the left side of the heart, cardiac shadow, in a normal chest X-ray PA view. Okay. So first is aortic arch, second is main pulmonary artery, next left atrial appendage, left ventricular apex. You please remember. Okay. You remember, we will see the first thing, first figure, so that you can easily make it. So this is the same thing. What we see is aorta, left pulmonary artery, left atrium, left left ventricle. We will not see this left pulmonary veins. We'll be seeing the left ventricle. Okay, left ventricle. And in the right side, you can see superior vena cava, right pulmonary veins, right atrium, and inferior vena cava. But in the heart, we'll be seeing superior vena cava and right atrium. Superior vena cava and right atrium in the X-ray. Superior vena cava, right atrium. Here aortic arch, main pulmonary artery, left atrium. So you understood. This is the normal thing. So we are talking about, we are going to talk about only the important abnormal things which we can see in the X-ray. So left atrium. So we all know that left atrium forms the base of the heart. Base of the heart. So when there is left atrial enlargement, what happens is double cardiac shadow. Very, very, very important. So double cardiac shadow is seen in dash. It is seen in left atrial enlargement. Double cardiac shadow, it is seen in left atrial enlargement. I repeat, double cardiac shadow, it is seen in left atrial enlargement. And this due to this left atrial enlargement, there will be straightening of the left border of the heart. Straightening of the left border. 1. Straightening of the left border. 2. Double cardiac shadow. There is left atrial enlargement. Okay. And also widened carinal angle. What is carina? Carina is the place where this trachea divides into principal bronchus. 2 principal bronchus, right and left principal bronchus. So the carina will be, that angle will be widened. So widened carinal angle, then straightening of the left border of heart, and double density sign, left atrial enlargement. The left atrium. Okay. Regarding the left ventricular enlargement of the left ventricle, it leads to boot-shaped heart. Boot-shaped heart. I repeat, left ventricular hypertrophy, boot-shaped heart. Left atrial hypertrophy, double cardiac shadow, and also what? Increased carinal angle, and also straightening of the left border of the heart. And when there is globular enlargement of heart, when all the chambers of the heart is enlarged, it leads to globular heart. And also in case of pericarditis, there is globular heart. Not pericarditis, when there is pericardial effusion. So what happens? This pericardium, it is filled with the fluid. So what happens? The fluid, like a balloon, it is swollen, and it is known as globular heart. Very, very important. I repeat, double cardiac shadow, left atrial enlargement, boot-shaped heart, left ventricular enlargement. Then what? That globular heart, when there is hypertrophy of all the chambers of the heart, or pericardial effusion. I hope you understand. So these are the important things which you will come across the question papers. Okay, what I am saying, only the medicine part of the, I mean the general medicine part of the cardiology, which I am saying. So regarding the echocardiography, this is the what next investigation as far as cardiology is concerned. So these are the only the important investigations we are going through. Okay, so there are 4 types of echocardiography. One is transthoracic, what we are usually doing. Echocardiography means like the UST of the abdomen, we are seeing the structure of the heart. So transthoracic echocardiography, real-time 2-dimensional slice. Okay, real-time 2-dimensional. You leave that. Then Doppler echocardiography, it is to see the blood flow within the heart and also great vessels. Okay, either within the heart means coronary artery and also great vessels. Then transesophageal. In transesophageal echocardiography, what endoscopy like structure is passed into the esophagus and it is kept behind the left atrium, and it is to visualize left atrium, pulmonary vein, interatrial septum, and also thoracic aorta. And also there is something known as stress echocardiography in persons where he cannot perform stress ECG, will go for stress echocardiography. So the important thing, transthoracic is the most common echocardiography we are using. Doppler echocardiography, blood flow. transesophageal in order to see the left atrium, pulmonary vein, interatrial septum, and also thoracic aorta. This slide is very, very important. So this is the direct statement from Davidson. A close relationship between symptoms and exercise is the hallmark of heart disease. So when a patient is doing some exercise or when a patient is doing exertion, when there is a relationship between, so when there is exertion, there is presence of symptoms. It is the hallmark of heart disease. So when there is exertion and there is some production of symptoms, it is the hallmark of heart disease. Very, very important direct statement from Davidson. Okay. So there is something known as New York Heart Association, and they have classified the functionality or exertional functionality of the heart disease. So there are 4 classes. Class 1 is normal, no limitation during ordinary. So there is no limitation during ordinary activity. Class 2, there is slight limitation during ordinary activity. Class 3, there is marked limitation of normal activities without symptoms at rest. That class 1 is normal. Class 2, in ordinary activity, there is slight limitation, slight discomfort is there. Class 3, there is marked limitation when there is normal activity. Class 4, unable to undertake physical activity without symptoms. Symptoms may be present at rest. So class 4 is symptom at rest. Class 3 is marked limitation. Class 2 is slight limitation. Class 1 is no limitation. You understand? And the important statement, I repeat, please keep in mind, please take a note of this. A close relationship between symptoms and excesses is the hallmark of heart disease. So next is arrhythmia. Arrhythmia, what is arrhythmia? When there is change in rhythm of the heart. Rhythm of the heart, and it is the cause of cardiac arrest, sudden cardiac arrest. What is cardiac arrest? When there is asystole. Suddenly the heart stops beating. When there is asystole, absence of systole. What happens? The heart stops beating. There is no blood flow. It leads to cardiac arrest. And the thing which I want to stress here, why this box is coronary artery disease. It is the most important cause of arrhythmic death. It is the most arrhythmic death means it is the most important cause of cardiac arrest. So 85% of the 85% of sudden cardiac death is due to coronary artery disease. You please make a note of this. The most important and the only most important cause. This 85% of cardiac arrest is due to coronary artery disease. Very, very important. So you don't go to the details and all. You understand the things. Okay. So you see, when you see a question that arrhythmia or arrhythmic death or cardiac arrest, the important cause is nothing other than coronary artery disease. Then structural heart disease is there. No structural heart disease. You please keep in mind coronary artery disease. It is the sudden arrhythmic death is the only most prime cause of sudden arrhythmic death. So this is regarding CPR. This CPR, sometimes they may ask in CPR, what is the what is the ratio of respiration to cardiac? We will be exciting the heart. So it is 30:2. For 30 excitation, 2 breath, 30:2. And defibrillation, what is the quantity of the electricity required? It is 150 joule. So for the first defibrillation, the electricity required is 150 joule, and one defibrillation, next CPR, and again if the patient is not reviving, the electricity needed is 150 to 200 joule. Okay, the important point you should keep in mind is 30:2. 30 cardiac thrust, 2 respiration. 150 joule first time, second time 150 to 200 joule, over. Nothing other than this in this slide. Okay. Then shall I continue? So I will continue. Normal and abnormal heart sound. So normal heart sound. We are going to discuss the normal heart sound now. Very, very important. You don't go out to all the details and all. Okay. You don't go to the details and all. You just see first heart sound. First heart sound. It is the closure of mitral and tricuspid valve. We have discussed already, is it not? First heart sound. It is the closure of mitral and tricuspid valve. It is during onset of systole. Nothing other than that. You see the only those things onset of systole. When the systole begins, there will be S1. There will be closure of mitral and tricuspid valve. So this mitral and tricuspid valve, it is present in between the atria and the ventricles. Mitral valve, it is between the left atria and left ventricle. Tricuspid valve, it is between the right atria and left ventricle. So what happens? Once the blood is flown from the atria to the ventricles, this closes. Onset of systole of ventricle. We are a systole of ventricle. So onset of ventricular systole, first heart sound, closure of mitral and tricuspid valve. Next, regarding the second heart sound, it is due to end of systole. So what happens at the end of the systole of the ventricles? This blood will be pumped towards the aorta and the pulmonary artery. So once the blood reaches the aorta and the pulmonary artery, what happens? Suddenly the aortic and pulmonary valve closes. Is it not? So it is the end of systole and it is the second heart sound. Hope you understand. First heart sound, closure of mitral and tricuspid valve. Second heart sound, closure of aortic and pulmonary valve. First heart sound, onset of systole, and second heart sound, end of systole. Okay. So usually we used to hear S1 and S2. Lap, 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 lap. Like that, we used to hear the stethoscope, the heart sound, and it is S1 and S2. So we used to write it as lap and dub, but we used to hear tick, 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 like that. So S1 is first tick and S2 is second tick. S1 is closure of mitral and tricuspid valve. S2 is closure of aortic and pulmonary valve. First heart sound is onset of systole. Second heart sound is end of systole. Okay. Okay. Next is third heart sound. It is S3. It is early in diastole, just after S2. So once the complete systole of the ventricle happens, what happens? This ventricle starts expanding. Is it not? So there will be diastole of the ventricle. So it happens early in the diastole, just after S2. So usually it will not happen. We cannot hear that. So, and it is heard as gallop. Gallop. What is gallop? That horse, the sound which we hear when the horse runs is gallop. Kolambadi. We used to see Kudira Kolambadi. That is gallop. So once the S3 is here, we will be calling it as gallop. Then fourth heart sound S4. S4 is end of diastole just before S1. Just before S1. See. So what is the cause of S3? S3 is abrupt cessation of rapid filling. That is when there is some problem within the valve. What happens then when there is stenosis? What happens? Stenosis means the diameter of the valve is reduced. So what happens? The aorta, what happens? This ventricle cannot push the blood as in case of normal. So what happens? There is in rapid filling, there will be cessation. Cessation means there will be slowing. So it leads to S3. You understand? Then fourth heart sound, S4. It is in case of stiff ventricle. Stiff ventricle. Stiff ventricle means when there is hypertrophy of the muscles of the ventricle, the muscles cannot operate as such. Is it not? So what happens? These ventricles will be very stiff. It will be very strong when it is hypertrophy. So what happens? When there is hypertrophy of the ventricle, there is chance of S1. Understand? S1 and S2 is normal. S3 and S4 usually abnormal. S3 is gallop and S3 is heard when there is abrupt cessation of the rapid filling, and S4 is here when there is stiff ventricle. Hope you understand. Then systolic click early or mid diastole. It is when there is stenosis, and opening snap when there is mitral valve stenosis. Opening snap. Systolic click is aortic stenosis or pulmonary stenosis. So you just remember all these things. There is a lot of pathology behind this, and this is not a time to explain the pathology. And if time permits, when we are having time, we will study it in detail. But in this time, it is not good to study all these things in detail. So S1 and S2. S1 closure of mitral and tricuspid valve. S2 closure of aortic and pulmonary valve. One is onset of systole, and second heart sound is end of systole. Third heart sound early in diastole from ventricular valve, and the fourth heart sound ventricular origin, stiff ventricle. Okay. Systolic click, valvular, aortic and pulmonary stenosis. Opening snap, mitral valve stenosis. Opening snap, mitral valve stenosis. Okay. Next. See, there is something known as murmur. Okay, murmur. You just understand there is something known as murmur. Murmur is the sound heard when the blood is flown through a narrow space. Okay, so you imagine your garden in your home. Okay, so with the help of hose, you will be watering the plants, is it not? Watering the plants. So when you water again or when you water tomorrow, you just hold the hose. You will be holding the hose at the end. You just hold the middle of the hose. Okay, you just hold the middle of the hose and you will be feeling a turbidity. That is, this through this narrow spaces, water will be flowing with more force, and you will be feeling feeling something. What? Some turbidity over your hand, and this is known as murmur. And the murmur we are not feeling with the hand, we are hearing with the stethoscope. It is due to increased turbidity or increased flow of blood through a narrow space. So if the space is narrow, the blood should be having more force in order to fall. So there are pathological murmur and also innocent murmur. What is innocent murmur? It is not the murmur of innocent. It is a benign murmur. This murmur, it is not having any problem. So how will you identify innocent murmur? So this is an important question. Innocent murmur will be soft. It will be mid-systolic. You understand? Innocent murmur, all the innocent murmur or benign murmur or murmur which has no pathology behind that is mid-systolic. All the innocent murmur are mid-systolic, but not all the mid-systolic murmur are innocent. Understand? Okay. So you remember this innocent murmur will be mid-systolic. It is soft. It is heard at the left sternal edge. There is no radiation of murmur and no other cardiac abnormalities. No other cardiac abnormalities. So I hope you understand. So this is the last slide of today's class. Some features of some common murmurs we are going to say. Okay. So aortic stenosis, common systolic murmurs. So in case of aortic stenosis, it is mid-systolic. Mitral regurgitation, it is pan-systolic. Ventricular septal defect is pan-systolic. And so you remember the most important valves working in our heart is aortic valve and pulmonary. Is it so? No, aortic valve and mitral valve. So it is concerned with the left side of the heart. So you remember these things. In case of mitral stenosis, you just take a note of this. In case of mitral stenosis and aortic regurgitation, mitral stenosis and aortic regurgitation, there will be diastolic murmur. Mitral stenosis, aortic regurgitation. And in case of mitral regurgitation and aortic stenosis, there will be systolic murmur. What that mid-systolic, pan-systolic and all we will study once the valvular heart disease we will be discussing. And you remember these things. In case of mitral stenosis and aortic regurgitation, there will be what? Diastolic murmur. And in case of aortic stenosis and mitral regurgitation, there will be systolic murmur. So these are the important things which I want to put in your brain in today's class. And next class will be dealing from the heart failure. Okay, heart failure. And hope you understand my session. Hope that this 1 hour is fruitful for you. If you are having any suggestions, please let me know so that I can modify the session in the future. And I thank the team Focus for giving me this opportunity, especially Dr. Regine for giving me this opportunity. Thank you so much. If you are having any suggestion, please let me know. Thank you.